Hello friends, welcome back to my YouTube channel that is ENT Chronicle, and today we're going to discuss about a very important topic, that is the nasal septum, and we'll also discuss about the diseases that happen in the nasal septum. So let's start a discussion with the definition of nasal septum. So what exactly is the nasal septum? So it is the mucosa covered bony as well as cartilaginous structure located in the midline of the nose, which separates the right nostril from the left nostril. Now, going by the definition in this diagram, we could see a central midline structure. Of course, we could see it is composed both of bony and cartilaginous structures. So, it divides the nasal cavity into two equal parts, right nostril and the left nostril. So, this structure is the nasal septum. Nasal septum, it is composed of three parts. Now, let's discuss the three parts individually. First, we have the columnar septum made up of cartilage. Then we have the membranous septum. It doesn't have no cartilage, only skin. Then we have septum proper. It is composed of both cartilage as well as bone. Let's start with the columnar septum. So, columnar septum is nothing but the unition of alar cartilage by fibrous tissue in the midline. So, in this diagram, we guys could see this side has the alar cartilage of both the sides, coming from laterally and joining in the midline with the help of some fibrous tissue. When this alar cartilage comes from laterally and joins in the central region, it leads to the formation of columnar septum. Whereas membranous septum is nothing but double layer of skin. It does not have any bone, it does not have any cartilage. Let me describe both the septums with the help of this diagram. So, alar cartilage, right alar cartilage coming from the right side and left from the left side and joining in the midline, leading to the formation of the columnar septum. Just behind the columnar septum, we have double fold of skin known as the membranous septum. And behind the membranous septum, we have the septum proper, made up of both cartilage as well as bone. So, the most anterior structure being the form of alar cartilage, that is a columnar septum. Then we have the membranous septum, just skin, no bone, no cartilage. And behind the membranous septum, we have structure which is bony as well as cartilaginous, that is our very own septum proper. So, now let's discuss the septum proper. So, septum proper is composed of both bones as well as cartilage. So, septum proper is formed of three major structures. So, let's discuss them one by one. So, the most superior one is the perpendicular plate of ethmoid. Alright, that's the first structure. Then we have another bone known as the vomer. That is the second structure. Third is the quadrilateral cartilage. Quadrilateral cartilage, or the other name we also know this cartilage as the septal cartilage. So, perpendicular plate of ethmoid, vomer bone and septal cartilage together form the septum proper. Just in front of the septum proper, we have the membranous septum, which is nothing but the skin. You guys could easily see this is just skin, there is no bone, no cartilage. And in front of the nasal septum, we have the columnar septum, which is composed of the alar cartilage. So, there are few other bones or minor contributions which contribute to the formation of the septum proper, although they are not very important. The three important being the perpendicular plate of ethmoid, vomer and the quadrilateral cartilage. These three structures should be on your fingertips. Amongst the minor contributions, the most important and frequently tested one is the rostrum of sphenoid, which is located this triangular notch right here, most posteriorly. So, minor contribution, let me enumerate them. First, we have the crest of nasal bone and the nasal spine of frontal. That's how I remember it, because crest of nasal bone and nasal spine of the frontal. Then we have already remembered the rostrum of sphenoid. Then we have two crests. First, we have crest of palatine and crest of maxilla. Then we have anterior nasal spine of maxilla. You don't have to remember these things by heart. You just have to remember these three structures, that is the perpendicular plate of ethmoid, vomer and septal cartilage, and you are good for it. Now, another very important point is how to draw the nasal septum. So, it is frequently tested in the university exams. So let's start this. Okay, so first of all you have to draw a U. Just follow my lead and draw point by point. So draw a U and then bring a line like this, go anteriorly and form a nose like structure. Then bring this line behind horizontally backwards and end it like here. Now posteriorly bring another line, move horizontally and straight, and join these two lines together and form a cavity in the bone. Now inferiorly draw the bony structure, that is the maxilla and the palatine parts like this, and then skin will come just symmetrical to the bone. Now this is the palate. All right, now let's draw the cartilage. Most posteriorly we have the minor contribution, that was the rostrum sphenoid, and from above we have the perpendicular plate of ethmoid. All right, then we have our very own vomer, and finally we have this right here. This area is reserved for the septal cartilage or the quadrilateral cartilage. So this is how you draw the following structure. All right, so this right here is the bone. Don't mind the diagram, I'm just drawing it for namesake, just so you know how to draw it in the university exams. This right here is the bony structure, and this one is the skin like this. This is the palate, and skin is present above the nose as well. All right, and finally we have this. Now let me just indicate the bones. This is the perpendicular plate of ethmoid, then this one is the vomer, and finally this one we have the septal cartilage. All right, now this is the rostrum of sphenoid, then we have the crest of palatine, and we have just here we also have the crest of maxilla. All right, then we have this we have the membranous septum, and most anteriorly you could draw alar cartilage, that would become our columnar septum. All right, so this is how you will draw the nasal septum in the exams. So the drawing part was easy. Now let's talk about two important things, that is the blood supply and the nerve supply of the septum. So in the nerve supply in the nasal septum we have 5 nerves. First let's talk about the difficult names. So first we have the medial nasal branch of what? Anterior ethmoidal nerve. All right, medial nasal branch of anterior ethmoidal nerve coming from above, this is. And next one is the septal branch of what? Infraorbital nerve coming from beneath. Then we have septal branch of what? Of anterior superior alveolar nerve right here. So these three include medial nasal branch of anterior ethmoidal nerve, septal branch of infraorbital nerve, and septal branch of anterior superior alveolar nerve. Along with this we have 2 more nerves, that is the olfactory bulb, and we also have the nasopalatine nerve. So as you guys could see, the olfactory bulb is present on the medial wall, that is the nasal septum. Any pathology, any chronic pathology of the nasal septum will affect the nerves as well. Thus, in any chronic pathology of the nasal septum, the olfactory bulb will also be affected, leading to conditions like anosmia as well as hyposmia. All right, that's a mini concept that you guys have to remember. Okay, so the nerve include olfactory bulb, nasopalatine nerve, septal branch of infraorbital and anterior superior alveolar nerve. Then we have medial nasal branch of the anterior ethmoidal nerve. Okay, now let's discuss the blood supply. Although I've discussed the blood supply in detail in the section of epistaxis, let's, for the sake of completion, let's discuss the few arteries here. So, external carotid artery gives two branches, maxillary artery and facial artery. Facial artery further gives branch, that is the superior labial artery. Superior labial artery gives a branch, that is septal branch. Alright, so septal branch of superior labial artery, greater palatine artery of the maxillary artery, branches of sphenopalatine artery and anterior ethmoidal artery all together supply the nasal septum, out of which there is formation of a small area known as Little's area. So Little's area blood supply is composed of septal branch of superior labial artery, greater and palatine artery, branches of sphenopalatine artery and anterior ethmoidal artery. Never is the posterior ethmoidal artery involved in the perfusion of Little's area. So only these four arteries are included in the Little area, leading to formation of the plexus known as the what? Kieselbach's plexus. Alright, this plexus is the main plexus involved in the bleeding of in epistaxis. Now we have discussed about the anatomy, the nerve supply, blood supply and the types of nasal septum. Now let's limit our discussion to the pathologies of nasal septum. So the first pathology that comes to my mind are the fractures of the nasal septum. So there is a very simple concept that you have to remember. Just remember two words, AJ and BC. Alright, if the blow of force is coming anteriorly, it would lead to the formation of gingival fracture. Therefore, anterior blow leads to gingival fracture. If the force is coming from below leads to formation of Chevalier fracture. Thus, anterior blow, gingival fracture. Blow from below, Chevalier fracture. Alright. If the blow is coming anteriorly, therefore gingival fracture is more horizontal, and if the blow is coming from below, the Chevalier fracture is more vertical in nature. Alright, now just remember AJ and BC and you will be sorted. Now let's talk about the treatment. How will we possibly treat the gingival and the Chevalier fracture? First of all, as soon as the patient complains or presents to you that he has some kind of trauma or somebody hit him on the nose, we will immediately drain the hematomas, as hematomas might convert into abscesses because of infection. After draining the hematomas, we will reposition the broken fragments. If there are any broken fragments of nasal bone or broken fragments of the septum, we will immediately reposition them. And finally, after doing the repositioning, we will support the nasal cavity and the septum with mattress sutures as well as nasal packing for the supporting. Alright, first we will drain, then we will reposition and finally we will support. Alright, if we are unable to treat the gingival and the Chevalier fracture, what could possibly happen? First of all, there can be permanent disfigurement of the septum, a term known as deviated nasal septum, and most common cause of deviated nasal septum is trauma only. Alright, if first of all it can lead to deviated nasal septum, there might be blood collection in the nasal septum. If this blood collection leads to any sort of infection, it will definitely lead to abscess formation, which is a surgical emergency. Abscess may even lead to perforation of the nasal septum. So therefore treating these fractures become highly important because they may lead to deviated nasal septum, hematoma formation and finally abscess, that is pus collection due to chronic infection. Alright, so we have covered the fractures of nasal septum. So next important topic is the deviated nasal septum. Alright, in these two diagrams, you guys could easily figure out what exactly is this DNS. So in the left side of my screen, we have something in the midline. Okay, it's equally dividing the nasal cavity into right and left nostril. But on my right side, I could see there is certain deviation in which one side of the nostril is that is the left side is more roomy than the right side. So this condition is referred to as the deviated nasal septum, a very, very, very important topic. All right. Now let's talk about the definition of the deviated nasal septum. It's a condition in which septum, instead of being placed centrally, it's central, it is normal, is inclined to one side or the another, leading to an increase in one cavity at the cost of another. In this diagram, it is beautifully explained. If it is deviated to one side, the one side of the nasal cavity will be more roomy, it will increase in size, whereas another side of the nasal cavity will decrease in size. And along with, the septum is not central as seen as in a normal person. Okay, so let's talk about the etiology. Why on earth does deviated nasal septum happens? Okay, the most common cause of deviated nasal septum is trauma. Let me mention here, most common cause is trauma, blow to the nose. Age and sex, it is more common in adults. Remember, more common in adults. For sexual preponderance, male are more susceptible to get deviated nasal septum as compared to female. Of course, hereditary is present. There have been few incidences of hereditary transmission of deviated nasal septum. For racial points, we have to remember that Europeans, the Caucasians, are much more susceptible to deviated nasal septum than the Asians. So Asians are less susceptible than the Europeans. High arch palate. For example, this right here is the patient of high arch palate. Just above the palate, this is the palate, and just above the palate we have the septum. Normally it should be straight, but as soon as the septum rises above, like this, the palate rises above, the septum is pressurized and lead to some sort of bending in its structure. So because of the excessive pressure of high arch palate, most probably adenoids in children, the septum gets deviated. So therefore high arch palate also leads to formation of deviated nasal septum. Okay, neoplasms. Although cancer is a very rare cause of deviated nasal septum, but imagine if some sort of neoplastic activity occurs on this side, it will most definitely push the nasal septum towards the opposite side. Therefore, if neoplasm is present, it may lead to deviated nasal septum, although very rare cause. Now there is something known as the BMT, that is the birth modulation or molding theory. Now during childbirth, by any cause, that is any malpresentation, forceps delivery, phased presentation, or prolonged second stage of labor, there is absolute BMT, that is bone molding theory, predicts because of all these interventions there is some sort of molding in the septum which leads to its deviation. Although these things are more important, that trauma is the most common cause, you might remember BMT as well. So we have talked about the etiology. Now let's talk about the types. Very important concept. Let's talk about the types. So there are 5 types of deviated nasal septum. The first one is the anterior dislocation. The second is the C-shaped deformity. The third is the S-shaped deformity. Right, here's the S-shaped deformity. And fourth is a nasal spur. And finally, fifth is a thickening of nasal septum. Let's talk about all these 5 in a little bit more detail. Alright, let's start with the anterior dislocation. Normally, what we see that septum is in midline and it is connected to the columella. Alright, both sides of the turbinates are of normal size. Okay, both sides of the turbinates are of normal size. But in anterior dislocation, the thing happen is the septum is anteriorly dislocated. This right is the columellar junction, leading to something, a picture, something looking like this. Alright, one side of the nasal cavity is quite roomy and other side of nasal cavity is not roomy. Therefore, this side might see the compensatory hypertrophy. Alright, a phenomena known as the compensatory hypertrophy of what? Of the turbinates. All right. So this was the case of anterior dislocation. Now second case we have of the C-shaped deformity. So normally should be straight, but in C-shaped deformity, the septum takes the shape of the alphabet C. Since it's taking a C shape, the turbinates will be hypertrophied on the affected side like this. So this is the C-shaped deformity. Next we have the S-shaped deformity or S-shaped deflection. In this we see something like this. Now the turbinates will adjust themselves. Again we will have the compensatory hypertrophy happening in the S-shaped deformity as well. One thing to remember, since both the sides are affected, neither air can freely pass right side, nor can it pass to the left side. So there is bilateral nasal obstruction. In the C-shaped deformity, this side there would be difficulty in passing of air, whereas the roomy side air will be easily passed down. All right. So there is unilateral obstruction in C-shaped deformity. Similarly, in the case of anterior dislocation, air might easily pass through the roomy part of the nasal cavity, roomy nostril, whereas air would not be able to pass through this part. So again, it is also leading to unilateral obstruction. So anterior dislocation, C-shaped deformity are both examples of unilateral obstruction, whereas S-shaped deformity is an example of bilateral nasal obstruction. Now next we have something known as the nasal spur. Alright, but before drawing the diagram, let me tell you the definition of spur. So spur is a spine at the junction of bone and cartilage. Alright, okay. Now we will draw the diagram. So this should be the normal septal cartilage, but the thing happen in spur formation is there is a spine. This right here is a spine coming at the junction of bone and cartilage. Now this spine impinges on the turbinates, completely blocking the airway. Alright, airway is completely blocked, and of course compensatory hypertrophy. So what is this type of DNS? It's a nasal spur which is impinging on the turbinates. All right. Again, let me tell you the definition of spur. It's a spine at the junction of bone and the cartilage. This right is the spine which is impinging on the turbinate. So composition is always asked about the spur. So spur is composed both of cartilage as well as the bone, but percentage of cartilage is higher than that of the bone. Now let's talk about the last one, that is the thickening of the nasal septum. Is nothing but the septum gets bilaterally thickened. All right, since it is getting bilaterally thickened, what kind of obstruction we will get in this? Air won't be able to easily pass on both the sides, so therefore it would lead to bilateral obstruction. Alright, what are the causes of thickening of nasal septum? It might be hematoma, or hematoma that changes into a septal abscess. Alright, it might be due to overridden septal fragments. So let me just take a quick revision. So there are 5 types. First is anterior dislocation. It leads to unilateral obstruction. Then we have C-shaped deformity right here. It leads to unilateral obstruction. Then we have S-shaped deformity or deflection leading to bilateral nasal obstruction. Like this. Then we have nasal spur impinging on the turbinates. And nasal spur is a spine at the junction of the bony and the cartilaginous part. Major component of the spur is the cartilage, not the bone. Alright, now fifth one is the thickening of the nasal septum. It is due to hematomas, due to abscess formation, or due to overridden septal fragments. It again leads to bilateral obstruction. Alright, nasal spur leads to unilateral obstruction, might as well remember. So let's talk about why is there compensatory hypertrophy of the turbinates. Alright, It's the pathology point of view of the deviated nasal septum. So a person acquired or congenitally DNS is present in the person. So simple talk is there. Due to deviated nasal septum, more air will enter on that side. All right. Since more air is entering on that side, it will lead to the dryness of the mucosa. All right. And when the mucosa will dry, there will be reflex vasoconstriction of the mucosa, and long-term vasoconstriction will lead to reflex vasodilation, and this reflex vasodilation will lead to the condition known as hypertrophy turbinate. So again, deviated nasal septum will lead to excessive air entry. It will lead to the dryness of mucosa. When mucosa will dry out, it will lead to vasoconstriction of the mucosa, and there will be reflex vasodilation. This reflex vasodilation is something which causes the hypertrophy turbinates. One little concept is there. Due to dryness of mucosa, parasympathetic system is affected, because of which there is reduction in sensation of nose. All right. And because of this, there is anosmia and hyposmia, as I've already discussed. So due to dryness, parasympathetic nervous system is affected in the nose. Now let's talk about symptoms of deviated nasal septum. Very important concept. Okay, so I've made a little mnemonic here, that is NAME, name, HHS. Now let's discuss. So we have already discussed air won't be able to pass through here. Okay, therefore first symptom would be nasal obstruction. All right, we have already discussed where it is unilateral, where it is bilateral. So first is nasal obstruction. Second, we have from A, we have anosmia. All right. Third is middle ear infections. Presence of deviated nasal septum, it's a predisposing factor to the occurrence of middle ear infections. From E, we have external deformity. All right. In this woman, we could easily see there is slight anterior deviation, and the deformity can be made out externally. Thus, DNS leads to external deformity, and it's a symptom. Then fifth, we have bleeding, that is epistaxis. Epistaxis, when the nasal septum rubs on the turbinates and the floor and the roof of the nose, it leads to bleeding. All right. From H, we have headache. All right. Along with headache, there was anosmia. Therefore, there will always be hyposmia. All right. And finally, eighth option, we have sinusitis. Since drainage is affected of this side, the meatuses are not able to drain the secretions from various sinuses. It would lead to inflammation of sinuses known as sinusitis. All right. Okay, let's move ahead. We have talked about the symptoms. Let's talk about the signs of the deviated nasal septum. Very, very, very important concept. All right. So signs can be made out externally, or they can be made out through the anterior rhinoscopy. One thing to remember, anterior rhinoscopy forms the part of investigation for deviated nasal septum in the patient. All right, let's move ahead. There are 3 points to be checked for signs in deviated nasal septum. First, of course, it's a nasal deformity. These 3 patients are here showing externally there is some sort of defect in the septum. Second is the cold spatula test. This little kid is undergoing the cold spatula test, in which there won't be enough condensation towards the blocked side. For example, this is the patent side of the nose and this is the blocked side of nose. There would be condensation of this side, whereas there won't be any condensation on the patent non-patent side. Now next test is very famous, the Cottel's test, in which we draw the nasolabial fold laterally. Okay. So we draw the cheek of the patient laterally and ask the patient to breathe. Okay, if the patient says that the breathing or respiration improves, it indicates the involvement of vestibular component of the nasal valve. For example, just imagine, so this is the nasal valve, these two angles. As soon as the person is made to lateralize its cheek skin, this angle slightly increases. Thus, more air passes. So this becomes the principle for Cottrell's test. So it indicates involvement of vestibular component of nasal valve. All right. Now, second point is of anterior rhinoscopy. So these are the things that you might be able to assess while doing an anterior rhinoscopy. All right. First, we might perceive the anterior dislocation as seen in this patient. Okay. We might as well see the side of dislocation, whether it is on the right side of the nose or the left side of the nose. We might even comprehend what type of DNS it is, C-shaped, S-shaped, or a spur or anterior dislocation. All right. We might even see the hypertrophy of turbinates. It's in this case, this turbinate is hypertrophied. We can assess the discharge, and finally we can see the mucosa if it is dry or it is congested. All right, all these things are found on anterior rhinoscopy, and it becomes the basis of investigation for a patient having DNS. But one thing you guys have to remember, if a patient presents with DNS, along with DNS, the patient also has signs and symptoms of rhinosinusitis. The patient is made to undergo a CT scan to rule out the causes of rhinosinusitis. Otherwise, anterior rhinoscopy is enough for diagnosis of DNS. But if the patient is presenting with signs or symptoms of rhinosinusitis, we will suggest him to undergo an CT scan. All right. Now let's come to the treatment part. Okay. So treatment is rather very simple. Just so, if the patient does not present with any symptom, although deviated nasal septum is present, a high number of patients have deviated nasal septum but do not have any kind of symptom. So these patients are left untreated until and unless they want to surgically correct for cosmetic reasons. All right. If there are symptoms like name HHS, we have already discussed the symptoms. If these symptoms are present, we will do what is known as the septoplasty. All right. So these two treatment regimens are important. If there are no symptoms, we will left it untreated. If there are symptoms, we will simply do septoplasty. Okay, guys. Now let's move our discussion to the next topic, that is septal hematoma. So as the name suggests, septum means septum and hematoma means blood collection. So going by the definition, septal hematoma is a blood collection in the subperichondral space of the septum. In this diagram, we could easily appreciate that this central portion is the nasal septum, this right here is the perichondrium, and in between these two structures, we have accumulation of blood, okay, referred to as septal hematoma. So there is blood collection. What might be possibly the cause of septal hematoma? It is due to trauma. Almost always due to trauma or secondary to any surgical process of involving septum. All right, it most common causes trauma or any surgical intervention that has occurred in the septum. So let's talk about the pathology. As soon as there is any trauma or any surgical procedure that has been done onto the septum, there would be accumulation of blood in between the septum and the perichondrial plane, and this excessive accumulation of blood in the subperichondrial plane will lead to the interference in the viability of the cartilage. So as you guys know, cartilage does not have its own blood supply. It is dependent on diffusion for its nutritional requirements. So normally, if there is hampered perfusion of nutrition supply of the cartilage viability stays normal for around 3 days. But after 3 days, if there is no treatment of septal hematoma, there is rampant death of chondrocyte and their absorption, leading to tissue necrosis. All right, so this becomes the pathology of the septal hematoma. Now let's move ahead and discuss the signs and symptoms of septal hematoma. So these right here is the signs of septal hematoma. First of all, obstruction is gonna be bilateral. In this image, you guys could easily see septal hematoma is present bilaterally. It is almost always present bilaterally. So if somebody asks what is the presentation in obstruction of septal hematoma, it is always bilateral. Okay, since it's an emergency condition, there's gonna be severe nasal pain, there's gonna be headache and mouth breathing, because of course there is bilateral nasal obstruction, because of which there is gonna be mouth breathing. Okay, next we have the signs of septal hematoma that we're going to see on anterior rhinoscopy. Okay, we have already discussed it's gonna be bilateral. The swelling which we gonna see is gonna be purplish. So this, since it's filled with blood, the swelling is going to be bilateral and purplish in color. Every single point on anterior rhinoscopy for septal hematoma is highly important. For example, it is bilateral, purplish in color, it is smooth since it's just blood collection, and it is fluctuant swelling over the septum. That means you might move it with the help of some pressure. Alright, bilateral, purplish, smooth, fluctuant swelling, like in this diagram. Alright. Okay, let's move ahead. So now let's discuss why is septal hematoma more common in children than in adults. The cause is mucoperichondrium. All right, the mucoperichondrium in children is slightly thicker. All right, it stays intact even after trauma. It is more elastic than adults. Since it's more elastic, it will collect more and more blood behind its membrane. All right. Next we have it's also remains intact after it also remained intact after trauma. Since it's intact, there's gonna be no blood leaking. That's why in children the mucoperichondrium is thicker. It remains intact after trauma, and it's highly elastic. And the fourth factor which makes septal hematoma more common in children is it is loosely adhered to the base. So basically it is more thicker. All right, and it remains intact even after trauma. It is more elastic, so it will just grow and grow and grow and grow and collect more and more blood behind it, and it is loosely adherent to the base, and thus its separation is rather very easy after trauma. All right, now let's discuss about how we're going to treat septal hematoma. Treatment is based on two factors. If the septal hematoma is large or septal hematoma is small. Okay, if septal hematoma is large, we will do incision and drainage. All right, if the septal hematoma is small, we will aspirate the blood using a wide bore sterile needle. It is as simple as that. If it is large, we'll simply put an incision and drain the fluid. If it is small, we will aspirate with the help of a wide bore sterile needle. Okay, what kind of incision do we give in IND for septal hematoma? The incision is small anterior-posterior incision which is parallel to the nasal floor. You have to remember these two lines, that it is a small anterior-posterior incision which is parallel to the nasal floor. Although the hematoma is large, but the incision is small. Okay, after doing incision, drainage and aspiration via wide bore sterile needle, we do the nasal packing in both the cases, for small hematoma as well as the large hematoma, to prevent refilling of blood, because the pressure of the pack will prevent blood from filling. Okay, broad spectrum antibiotics are given to the patients in both the cases, for large as well as small hematomas. Why do we give broad spectrum antibiotics? We give it to prevent septal abscess, that is pus collection. So we have completed the topic of septal hematoma. Now we will discuss something known as the septal abscess. So till now you have guys talked about anatomy of the nasal septum. We have talked about fracture of nasal septum, septal hematoma, and septal abscess is nothing but a sequel of septal hematoma. As soon as the septal hematoma is infected, it leads to the formation of septal abscess. So what is septal abscess? It is collection of pus. Abscess means pus, right? In subperichondral plane of the septum. Etiology: it is always secondary to septal hematoma. Hematoma get infected and leads to formation of septal abscess. So this right here is a septal hematoma, purplish discoloration due to collection of blood. It's get infected due to non-treating of the cause or problem in drainage of the blood. It will lead to formation of pus, that is the abscess of the septum. All right, so let's move ahead. Let's discuss about the signs and symptoms. So since it is an infective pathology, septal hematoma gets infected, therefore there's going to be infective features, that is fever and malaise. Again, there's going to be bilateral nasal obstruction. There was bilateral nasal obstruction in septal hematoma. Therefore, there's going to be bilateral obstruction in septal abscess as well. There's going to be pain as well. It's an infective pathology. For signs, we will first of all see there's going to be febrile. The patients will have fever because of underlying infection. There will be a tender swelling on the septum. The swelling is soft and fluctuant. These 2 points are rather similar to the septal hematoma, but fever and submandibular nodes enlargement, which may or may not be present, is typical feature of the abscess. All right, so let's quickly discuss the differentiating features of both hematoma and abscess. So when we aspirate hematoma, what we will see? We will see blood. And when we will aspirate abscess, we will see accumulation of pus. There's gonna be fever. In hematoma, no. There will be no fever. But abscess, fever will be present because of the infection. What will the color of the swelling? It will be pinkish, reddish and purplish. Whereas it will be yellowish because of the pus and pale. Lymph node enlargement. Would it be present in hematoma? No, it won't be present in hematoma. Whereas lymph node enlargement, typically the submandibular lymph node, we will may or may not see, but it is most definitely seen in the septal abscess and not in the hematoma. All right, now let's discuss about, we have discussed the signs and symptoms. Let's discuss about the treatment. All right. It's a surgical emergency. Septal abscess is surgical emergency because the patient may experience sepsis and may even collapse due to septal hematoma abscess. So it's very urgently treated. So first we will there will be incision and drainage as soon as possible. So incision is made on the most dependent part of the swelling. As you guys could see in this patient, there has been the doctor made an incision and the pus has started draining out of the swelling. Okay, along with IND, incision and drainage, small piece of septal mucosa is also excised. Septal mucosa is removed so as to prevent formation of further pus and blood collection. Since there is accumulation of pus, there will be a necrosed tissue as well. So we will remove the excess pus or remaining pus in necrosed tissue with the help of suction machine. All right, and since it's an infective pathology, we will give broad spectrum antibiotics to the patient for around 10 days. So 10 days broad spectrum antibiotics. So I've attached an image. So this patient underwent an IND, incision and drainage, for drainage of septal abscess. Right here you could see it is central portion is the pus, and then we could also see the blood portion, and then the patient underwent nasal packing to prevent further refilling. So what we do, incision and drainage, we will remove some part of the septal mucosa, we will, via the help of suction, we remove the necrose and dead tissue, and we will give broad spectrum antibiotics for 10 days since it's an infective pathology. Okay, what are the complications of septal abscess? Septal abscess is a very dangerous condition. Okay, it may lead to septal perforation due to death of chondrocytes and excessive necrosis, because period of viability of cartilage is mere 3 days, and after 3 days the cell starts to die. Since because of excessive septal perforation, the bridge of nose may collapse, and because of this collapse, it will lead to some condition known as saddle nose. Now there are two conditions: facial cellulitis and cavernous sinus thrombosis. Since we know abscess collection is happening around here, which coincidentally also forms a part of danger area of face. So this right here is the danger area of face. Since septal hematoma, septal abscess is occurring in this triangle right here, it will lead to the facial cellulitis and cavernous sinus thrombosis. So guys, this was all about a discussion on the septum and its pathologies. I hope you liked the lecture. If you like the lecture, please share, subscribe to my channel, and thank you.